Hi everyone, welcome back to part 2 of section 10, musculoskeletal complaints. We are going to get started with wrist and hand. The book jumps right into the types of tests that you can do to assess for wrist and hand pain. These tests include Allen's test, Phelan's test, Tinel's test, and the Finkelstein test. They all have different purposes. The Allen's test is to assess patency of the radial and ulnar arteries and the arterial arch. Phelan's test is to assess medial nerve compression. Tinel's test is to assess for compression neuropathy, and the Finkelstein's test is to Quevron's disease, and so based on what those findings are will determine what next steps you take to help your patient with those pains in the wrist and the hand. Next, the book talks about hip pain, and this is pain in and around the hip that can be felt often in the groin or in the buttocks and can be referred to the thigh or knee. With this patient, it's important to do a good range of motion exam and to assess further gait, and then put each extremity through a passive range of motion to look for any limitations of movement, muscle spasms, contractures, guarding, or crepitation. Flexion and extension should be performed with the knee straight out as flexed, and then also assess for abduction, adduction, and internal and external rotation. It's important to check for pulses and assess their strength, and then do a neurological test for sensation and deep tendon reflexes. To further assess this pain, X-ray films of the hip are beneficial. Location of the pain in the hip can give clues to where and what the etiology might be. If the pain is in the groin or the inguinal fold, the pain may be related to the anatomy of the hip. If the pain is in the anterior hip and radiates to the lower back or into the trochanter area, this could be considered trochanteric pain syndrome. If the pain is posterior and radiates to the lower back or causes muscle strain, this can also help with diagnosis. Next, let's talk about knee pain. And this is another complex joint that is hinged and has 3 bones, 3 articulations, 5 major tendons, 4 major ligaments, and 2 menisci. The knee itself is a relatively weak joint, but it gets its strength from strong ligaments that attach to the femur, to the tibia. So being a major weight-bearing joint, it's susceptible to many injuries. Any motion that extends beyond the defined range of the ligaments can cause injury. The knee joint is a common site for pain due to trauma, and these could be related to fracture, meniscal injuries, ligament injuries, muscular tendon strains, extensor mechanism injuries, and contusions. Many knee complaints are due to overzealous exercise or high intensity sports. Fractures can occur, so it's important to assess for swelling and any deformities, palpate for tenderness, and if necessary, get radiology involved. It's important to get a good history of the injury, as that will help with diagnosing meniscal tears. You want to know if there's been any twisting injury while the foot was planted on the ground. Some of these patients report a pop sensation, and that can help in diagnosis. Patients with ligament injuries can have acute pain, swelling, and instability of the knee. Chronic knee pain is often unrelated to recognized injury or overuse, and it can be caused by arthritis, tumors, sepsis, or overuse syndromes. In the book on page 807, there are tests to assess the meniscus and the patella. Special tests, the McMurray, the apprehension, the bulge. Several of these are listed as videos, so I encourage you to review those and feel more comfortable with how you can do these tests and incorporate those into your care. Next, let's talk about foot pain, and it's a common problem. According to a study by Framingham of older adults, approximately 19% of men and 25% of women have significant foot pain on most days of the week that limits their ability to function. So I anticipate that this is a common complaint that you may see in practice. It's important to include a foot exam as part of your routine evaluation of older patients. If there's any conditions that can cause pain to the foot, then that can definitely impact how well your patient is able to move around. Those could include hammer toes, corns, calluses. In the book on page 809, there is a list of differential diagnoses associated with foot pain that range from the forefoot to the midfoot to the hindfoot, and what these particular issues might be, and then the management of those conditions. So be sure and review those. Next in our slide deck, we have different videos on assessing the wrist. So like we mentioned, I encourage you to look at those. As I said, these have not necessarily ended up in the right format that I would like. Please use them as references to come back and look at. This is one on knee pain differential diagnoses. This is some malalignments of different issues with the knees. This is a diagram of what a normal knee would look like, a genu valgum where you're more knock-kneed, and genu varum where you are bowed, and that's what these following slides are in reference to. So it talks about the different angles of the knees, potential causes, and what some of the consequences of those changes in angles might be. In this slide, we're talking about the anterior drawer test to test for ACL stability. This one is the posterior drawer test for a posterior cruciate ligament laxity. Some different videos, so be sure and review these in regards to knee exams. Let's see how far this goes. These are all about knee exams. More knees, meniscal tears. Let's talk a little bit about spinal disorders. Next, let's talk about some spinal disorders. We're chapter 53 on page 814 in the book if you are following along that way. So cervical muscle sprain and strain are injuries of the neck and are largely self-limited condition. Most of it is related to mechanical disorders of the cervical spine. The soft tissue muscles of the neck are buried deep and they're very protective, and it's often difficult to differentiate injuries to the neck by either physical exam or by imaging. Pain is often the most common presenting symptom, and these patients can also have complaints of headaches, usually in the occipital region, that may be persistent for months. Pain is usually in the middle to lower part of the posterior neck, and it may be limited or it may cover a large area, and it can radiate to the shoulders but usually does not radiate down into the arm. On physical exam, you will note a decrease in neck range of motion. Frequently there's tenderness on palpation of the anterior and posterior structures of the cervical spine, and specifically in the paraspinous muscles and the interspinous ligaments. These can be tender to touch. If there's concerns on your exam for neurological deficits, then diagnostic testing would be needed, such as x-rays or MRIs to determine the cause. The book mentions that for hyperextension cervical injuries, that soft tissue damage is typical, but plain x-ray films for the cervical spine should always be obtained. And this is to assess for any unsuspected fractures or dislocations of the cervical spine. Management includes decreasing activity to allow the injury of the tissues to heal. NSAIDs are helpful for pain management. As we mentioned before, short-term use of muscle relaxants may be appropriate. Neck pain and mobility are improved with physical therapy, and the goal of this therapy is to maximize function of the cervical spine. So this could include both cold and heat, which can help relieve pain and spasms, and activities should be encouraged as determined by the severity of the symptoms. Next, let's talk about cervical spondylosis, and this is a larger term for a group of chronic degenerative conditions that affect the vertebrae and the facet joints and can cause pain, stiffness, and disabilities. Spondylosis can occur in the lumbosacral and the cervical regions of the spine. The most common symptoms are recurrent neck stiffness and mild aching discomfort, especially with activity. If these patients have radicular symptoms, that can extend, testing may find that there's weakness in the shoulder abduction muscles, the bicep weakness, and tricep weakness. Diagnostic tests for this condition would include assessments of the cervical spine, and these could include an MRI. Treatment includes possibly cervical traction if radiculopathy is noted. PT would help strengthen the neck and teach proper body mechanics. Also may include NSAIDs to help with pain management. If conservative measures do not work and symptoms persist, oral steroids may be used, and then evaluation for epidural injections may be needed. Next, let's briefly talk about lower back pain, and it's an injury to the paravertebral spinal muscles. Lower back pain can impact approximately 70% of adults at some point in their lives, and about 90% with acute lower back pain spontaneously recover within 1 month. However, back pain can be associated with neurological deficits where you may have decreased or absent pulses, may also have bowel or bladder dysfunction, and can be potentially life-threatening and warrants immediate referral. So it's important to differentiate whether this is an acute lower back pain that has persisted for less than 6 weeks or a chronic lower back pain that's lasted longer than 3 months. There's a great table on page 819, table 53.1, that are red flags when assessing a patient with low back pain. Be sure and review that because it has it in 4 columns if you suspect a trauma, some things that you might see that are red flags: suspect of a tumor, suspect of an infection, suspect for radiculopathy or a cauda equina syndrome. So these are some red flags that you should be aware of. There is a section in this part of the book focusing on your lower back pain and questions that you need to ask that may be helpful in gaining that history to help guide what your plan of attack will be. Some special tests to conduct to assess lower back pain include straight leg raises, and there's a couple of different ways that you are able to do different testing, and that's found on page 820. Management of acute lower back pain is usually resolving on its own. It usually resolves in 1 to 6 weeks. Symptoms can be controlled to help the patient overcome activity intolerance. Someone with chronic lower back pain requires more of what the book calls a circle of caring by the practitioner. There's a variety of approaches. As we've seen throughout this book, there is the iceberg diagram of lower back pain, and so be sure and look at page 822, and this discusses the different tenets that can go into managing low back pain, including short-term Pharmacology therapy, surgery, lifestyle changes, psychosocial, complementary therapies, self care, and patient education. So, all of these play an important role in helping to manage lower back pain. Next, let's talk about herniated lumbar disc. This is one of the most common causes of radicular pain to the lower extremities. We know that our lumbar disc receive a lot of exposure and carry large loads um, in our spines, and in some individuals there can be a fragmentation of the disc followed by a rupture and then herniation of the nucleus pulposus into the lumbar canal, and this results in herniated disc syndrome. It can cause pain, numbness, or weakness in one or both of the lower extremities. This one-sided radiculopathy is frequently accompanied by lower back pain. Patients may report um, that the back pain disappears when the leg pain begins, and this is a signal of of when the herniation occurred. Pain may be severe and exaggerated by sitting, walking, standing, coughing, or sneezing. Most of the pain radiates from the buttock to the posterior or posterior lateral leg to the ankle or the foot. Most of these patients can't find a position that they're comfortable in. With the disc rupture, there may be paraspinal muscles that cause spasms and lumbar scoliosis, and patients may seem to tilt to one side or another. If you have concerns for a herniated disc, then it's important to check for deep tendon reflexes and to assess neurological functions. The straight leg test should be done on both of the involved and uninvolved limbs with the patients on their back, and that's going to give some good information. I believe that one of the videos in this chapter in the PowerPoint deck gives demonstration of that. If the problem persists for longer than 3 to 6 weeks, or if there's evidence of any red flags, then a referral would be indicated. Moving on, let's talk about lumbar spinal stenosis, which is a narrowing of the lumbar spinal canal and compression of the nerve roots. Symptoms may begin following a lifting incident or if there's been a minor trauma. Muscle weakness is noted in the legs, and this is more subtle, and it um, and this may be best elicited after walking on a treadmill. The patient may have a positive Romberg test. With these patients, it's important to manage for any neurological deficits, if there's any gait issues or bowel or bladder dysfunction. Use of NSAIDs may be helpful, as well as folic acid and B12. Most management will include physical therapy or an exercise program that focuses on flexing the spine. Sorry for the pause there. The patients may have a stumbling gait from leg weakness, and you may note quadriceps and hip extensor weakness as the patient has difficulty rising from a chair or using the armrest or seat to push themselves up. If there's concerns for a cauda equina compression, then a surgical lumbar decompression is necessary to halt any further neurological deterioration. Okay, we're going to push on to chapter 54 and talk about soft tissue disorders. And the first one we're going to talk about is bursitis, which is an inflammation of the bursa and can cause painful musculoskeletal concerns. As we all know, the bursa is the sac that is filled with synovial fluid, and it's located between muscles, tendons, and bony prominences. Been talking for too long. The bursa provides lubrication to the joints and for the movement of tendons over bones. So it has an important function. Um, Patients usually present with pain or swelling in the areas of the bursal sac. Clinically, you want to check for if there's any induration, if there's any redness, or if there's fluid collection where the pain is. You're looking for if there's a swollen appearance. The patient may have a limited range of motion or pain on flexion. Management of bursitis includes avoidance of activities that can lead to the constant irritation of the bursa and using a moist heat or ice for the affected areas. You may need to immobilize the area to reduce swelling and to provide support. If symptoms reoccur, long-acting corticosteroids can be used to help with the pain. Physical therapy can play a role in shoulder and hip bursitis. And if continued pain is still there after about 6 weeks, then referral to an orthopedist may be needed. Next, we're going to talk about tendinitis and tenosynovitis. And as we know, tendinitis is inflammation of the tendon, and then tenosynovitis is inflammation regarding or involving the synovial sheath surrounding the tendon in addition to the tendon. These are most commonly seen in overuse syndromes or repetitive motion issues. Common anatomical sites can include the shoulder, the forearm, the hands and the wrist, and the legs and the feet. Patients typically present with pain or swelling over a localized area of the tendon in a usual region where the tendon passes through a tunnel. A thorough history is needed, including all extracurricular activities. Physical exam should be palpation of any tender areas and rule out any articular involvement of pain. Swelling may be minimum, but it may be increased in cases of infection or if there's inflammatory concerns. These patients complain of pain and swelling over the tendon, usually, as I think we mentioned earlier, and this may be a repeat, and I apologize, of where the tendon passes through a tunnel. Diagnosis is based on symptoms. Early imaging usually is not beneficial unless there is some calcifications in the tendon that may be seen on a routine exam. You're going to palpate tender areas and rule out any articular involvement of pain. You may notice localized pain, swelling, and tenderness, and the pain may be worse in certain positions. If there's concerns for an inflammatory issue, there may be associated redness, soft tissue swelling, and warmth. Plain films may be useful to rule out potential causes of pain in the area, but they will not show tendinitis. Treatment will depend on the stage of healing to the area, and there are 3 phases of healing: inflammation, proliferation of new collagen and ground substances, and the scar remodeling and maturation. Initial management should be the PRICE acronym that we've talked about several times: protection, rest, ice, compression, and elevation. Taping and bracing may be helpful in providing protection. Ice is useful in treating pain. Heat can be used 48 hours after the acute phase and in chronic phase. NSAIDs have their place in helping with inflammation. Corticosteroids can be indicated in chronic overuse syndromes. Referral to a physical therapist should be considered. All care should be individualized based on the symptoms that the patient has, and occupational therapists can assist with fitting splints if necessary. Next, let's talk about carpal tunnel, and is the most common cause of peripheral nerve compression and can impact anywhere from 3 to 6% of the adults. Symptoms tend to impact the dominant hand, but over half of the patients have bilateral symptoms, and women are 3 times more likely than men to be diagnosed with carpal tunnel. Subjectively, the patient will present with an aching sensation that radiates into the hands. Hallmark symptoms are nighttime awakening with pain and numbness. On exam, you should inspect the wrist and hand for swelling, any redness, nodules, deformities. The thenar eminence, which is that area at the base of the thumb, is the best location to assess for atrophy. And if it appears to be atrophied or flattened, chronic carpal tunnel syndrome should be suspected. You're going to want to palpate all of the interphalangeal areas, the distal, the proximal, and the metacarpophalangeal joints should be palpated, as well as the wrist bones. You may want to perform the Allen's test, the Phelan's test, the Tenniel's sign, and we have videos previously in this PowerPoint that show how to do that. Treatment is typically conservative for the majority of patients. The goal is to prevent flexion and extension movements of the wrist. Splints are often very beneficial to help with that and allows free movement of the fingers, but keeps the wrist in a neutral position. NSAIDs can be appropriate in helping with pain management along with splinting. They also are very helpful in reducing swelling in the carpal tunnel itself. If there's continued symptoms and conservative measures are not helping, then referral to a surgeon, hand specialist, etc. should be considered. Next, let's talk briefly about de Quevron's tenosynovitis. And this is where the APL and the extensor pollicis brevis tendons exert excessive friction on the synovial sheath, causing inflammation. And it's characterized by pain at the base of the thumb. This pain on the radial aspect of the wrist is usually associated with lifting, and it can be aggravated by attempts to move the thumb or make a fist. Your physical exam is similar to carpal tunnel syndrome, and the same diagnostic studies will be completed. Management is similar, and if symptoms are not resolving after 6 to 8 weeks of conservative therapy, then referral to an orthopedic surgeon is recommended. Some other hand and wrist disorders in the soft tissue disorder category include ganglion cyst that develop on the tendon or the sheath, and it's a thick gel-like material that leaks from the joint and can weaken the tendon sheath and forms a sac. A trigger finger or a locked finger is the common name for stenosing tenosynovitis of the flexural tendons. And this is any digit can be impacted, and it's where the finger can get locked into place. You have inflammation of the MCP joint pulley and can cause discrepancy between the tendon and the pulley. This is more common in middle-aged women and is associated with RA or with diabetes. Most effective therapy is local anesthetic and a corticosteroid injection into the tendon sheath, plus modified activities for about a month. Surgical intervention may be required. Splinting and NSAIDs have not found to be effective. In shoulder disorders, we have a couple mentioned in the book: adhesive capsulitis, rotator cuff syndrome, rotator cuff tears, and shoulder sprain. For adhesive capsulitis, that is often referred to as frozen shoulder, and it's defined as an idiopathic loss of both active and passive range of motion. Patients are usually between 40 and 60. They can be diabetic, especially type 1 is the most common risk factor. Patients with diabetes tend to be refractory to treatment, and 40 to 50% of them will have bilateral involvement. Rotator cuff syndrome may include impingement problems, calcifications of the tendon, and subacromial bursitis, so a shoulder bursitis. And this impingement syndrome refers to when the bursa or the rotator cuff becomes inflamed because the compression under the acromion um, of the shoulder joint. It's the leading cause of shoulder pain and can range from bursitis to a rotator cuff tendonitis. And eventually there can be degenerative tears of the rotator cuff. A rotator cuff tear can occur secondary to trauma or from degenerative changes or chronic mechanical impingement. A couple of tests that are used to assess this are the empty can test and the dropped arm test. So be sure and review those different tests that are in the book. Next are hip disorders, and I want you to read about those in the book starting on page 845. We are going to get into more detail with osteoarthritis and osteoporosis in the next chapter. Also review ankle disorders, ankle sprains, and management for those. And we will move on to the next chapter and talk about osteoarthritis and osteoporosis. So in chapter 55 on page 851, we're talking about osteoarthritis, also known as degenerative degenerative joint disease. And it is one of the most common articular diseases in older adults 45 and up. It's a gradual progressive joint disease, and it typically affects the hands, the knees, and the hips. Although osteoarthritis occurs in women earlier, the prevalence among men and women is equal. Additional risk factors include genetics, joint injury, past trauma, obesity, and mechanical stress. Be sure and review the objective findings on page 853. In the hands, there can be enlargement of the joints. The thumb may be enlarged. There can be swelling in the feet, in the knees and hips. You can have crepitation with passive range of motion. So be sure and review those details. On page 855 in table 55.1, there is a good chart that talks about the diagnostic criteria for osteoarthritis in the hands, the knees, and the hips. So I encourage you to look at that. This includes both the history and physical components as well as laboratory findings, if necessary, and radiological findings. The principles of management for osteoarthritis are to control pain and symptoms, to maximize functionality and to promote independence, to minimize disability, and to preserve quality of life. There are numerous self-care strategies that can be incorporated in. It's important also to not forget the role of physical therapy and occupational therapy. And then there can be complementary therapy such as acupuncture and nutritional support. From a pharmacology perspective, there are different guidelines and recommendations based on where the osteoarthritis is. So for hands, the recommendation is to use topical capsaicin, topical NSAIDs, oral NSAIDs, and tramadol. For knee, it's recommended Tylenols, oral NSAIDs, topical tramadol, and intra-articular corticosteroid injections. For hip, the recommends for initial management, obesity management, non-narcotic management, the use of NSAIDs, PT, joint injections, and then management of depression, anxiety, and psychosis that can impact pain relief, function, and activities of daily living. Lastly, we're talking about osteoporosis, which is the normal bone mineralization, but it has low bone mass loss and distribution of the bony architecture. and both of these places the patient at increased risk of fractures. These fractures are primarily seen in the vertebral and hip fractures, but they can occur at any skeletal site. And just be aware that osteopenia is the less severe form of decreased bone mineral density that can then progress to osteoporosis. Risk factors include age, tobacco use, eating disorders, family history, increased alcohol intake, and a sedentary lifestyle. There are disease-related risk factors, and these include hyperparathyroidism, RA, inflammatory bowel disease, chronic renal insufficiency, malabsorptive disorders. Medication can increase your risk factors, glucocorticosteroids, excessive thyroxine, long-term use of phenotone. Then other risk factors, as we talked about, advanced age, family history of osteoporosis, postmenopausal, and genetic predisposition. The goals of osteoporosis are to prevent fractures, stabilize and improve the bone mass, and maximize physical functioning. You want to make sure that these patients are in a safe environment at home where you are minimizing falls. They need to be supplementing with calcium and vitamin D, and then the role of bisphosphonates in strengthening bones. On page 869, the book describes medications that are used for the treatment of osteoporosis. You have your bisphosphonates, you have your parathyroid hormones, and there is also monoclonal antibodies. So be sure and review those, and so you're familiar with treatment options that you might see your patients being on. I think that is the end of section 10 and of our PowerPoint deck. Thank you for your time, and if you have any questions, please feel free to reach out. Thank you.